Good morning, and thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Kate Crump with the New England QIN-QIO. This is our fourth webinar from our 9-month educational series, Navigating Infection Control and Antimicrobial Stewardship in Long-Term Care, brought to you in partnership with the Massachusetts Department of Public Health and Tufts Medical Center. Today's webinar will focus on infection control prevention. Before we begin today's program, I have a few housekeeping items to review. The webinar will be recorded. The presentation recording and transcript will be posted to the event page. The phone lines will be on mute for the duration of the presentation. Feel free to use your phone's manual mute button as an added precaution, but please do not put your line on hold. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. Please make sure to send your comments to all participants. Ellie Fisher from the QIN-QIO team in Massachusetts will be monitoring and responding to questions and comments in chat. We will also have time for questions at the end of the presentation, and we'll open the phone lines for questions at that time. Lastly, if you find the presentation appears a little cut off, please use the plus or minus icons in the top right of the presentation window to hit your screen. I will now mute the lines. An automated message will play. Speakers, please unmute yourself after the message by pressing #6.
The leader has muted your line. To unmute your line, press #6.
Now, to introduce our first speaker, I'm going to turn it over to Melissa Cummings from the Bureau of Infectious Disease and Laboratory Sciences and the Massachusetts Department of Public Health. Melissa?
Good morning. Thank you, Kate. On behalf of the Massachusetts Department of Public Health, I'd like to welcome everyone to today's webinar. It's my pleasure to introduce once again Dr. Shira Doron, who will be our presenter today. Dr. Doron is a physician in the Division of Infectious Diseases at Tufts Medical Center. She has been the physician head of the Antimicrobial Stewardship Program since 2005 and is also the Associate Hospital Epidemiologist. And with that, I will turn it over to Dr. Doron.
Thank you, Melissa. We have an ambitious agenda today, and I've put this presentation together a little bit differently, and not to scare anyone, but there are actually over 80 slides in this deck. But that doesn't mean I'm going to go through them all in detail, because certainly we don't have time for that, and I think it would get a little bit boring. But my goal in creating such a comprehensive slide deck today is you will have access to these slides for future reference, for as long as you need them. And this is a big topic. This is infection control prevention. And there are a lot of elements here. In particular, I think to your interest will be the elements that are essential to an infection control policy. And so I put a lot of detail into this so that you can use it as a reference. Also, we're going to compile for you a list of all of the web-based resources that I'm going to mention. So don't furiously copy down URLs, certainly. You'll have access to these slides, and then we'll send you a separate list of web links for your use in implementing infection control prevention activities. In addition, we're going to talk about key strategies for preventing device-associated infections and healthcare-associated infections in general, and then review the steps that are required to prevent the spread of highly resistant bacteria. So jumping right in thinking about infections as they relate to the harm that comes to skilled nursing facility residents, infections are among the most common cause of harm. In fact, they account for 26% of adverse events, and actually 59% of those infections have been deemed to be preventable, and this is based on a 2014 report that you see referenced here among Medicare beneficiaries. Transfers to hospitals from infection events are extremely common. Actually, 87.2% of these patients or residents in this report were transferred to the hospital. And this has a really big impact. We're talking about 1.6 to 3.8 million healthcare-associated infections, and they're a leading cause of mortality, morbidity, in fact, resulting in 388,000 deaths that's been estimated. And 1,000 to 300,000 hospital admissions, 26 to 50% of those due to infection. So we're talking about up to $2 billion in cost of hospitalizations. And you see here something below, something we've talked about quite a bit. Up to 70% of residents receiving an antibiotic, which is why we've been talking so much about stewardship and antibiotic resistance. And so here's some more detail on the Office of the Inspector General report. And just here, quickly, I'm just going to highlight the fact that although 26% of infections, 26% of adverse events are due to infection, 52% of the preventable adverse events are due to infection, and it's the highest, it's associated with the highest estimated total spending of all adverse events. And yet we have these really huge challenges in long-term care. We have, unfortunately, a lack of resources, with less than 30% of nursing homes having full-time infection prevention staff. Also have a lack of expertise. Less than 10% of infection prevention coordinators receive formal training. Then you have the communal living aspect, where you need to balance the needs of the resident to socialize and to rehabilitate against the benefits of isolation to prevent transmission. We simply cannot isolate all of our residents who might be colonized or infected with epidemiologically significant organisms and still provide them the care that they need. And then, as you know, we have a high staff turnover and lots of part-time personnel, and both of those factors affect your ability to engage your staff and to educate your staff in the area of infection prevention. Nevertheless, despite these challenges, we don't have a choice anymore. The final common rule by CMS, the Center for Medicare and Medicaid Services, states that we now are subject to requirements. In Phase 1, which was implemented in November of 2016, every skilled nursing facility was required to have an infection control program. In Phase 2, which became implemented in November of 2017, every facility needs to have both an infection control program and an antibiotic stewardship program. And next year, in 2019, every skilled nursing facility will be required to have an infection control program with an infection preventionist that has formal training. So I encourage you to read the details of the final rule, and the URL is here, and we will send that to you. And there's a lot of information in there that I would suggest you use as the starting point and incorporate the elements of that final rule into your policy. And the details there include things like vaccination schedules for residents and staff, things like who should be on your infection control committee, how often they should report, and to whom. So take a look at all of that, and you can go step by step and make sure that each one of the elements of the rule are in your policy. Now we'll talk about some of the ways to achieve compliance. You want to be sure that you're reviewing your facility's policies and procedures at least annually and revising them at least every 3 years, modifying, creating new policies and procedures as things arise. You want to identify the staff who should be part of the review process and the development process for those policies and procedures. You certainly want to make sure that you're developing and implementing staff training in all of the areas that we're going to discuss today. And if you don't have this already, you want to create a trained IT position. And by next year, you want to make sure that you have in place a way to obtain that formal training for the infection preventionist. And I'm going to show you a great option at the end of this lecture. And make sure you're adhering to that timeline for completion of the new requirements. So infection prevention programs should already be in place. Antibiotic stewardship programs should have already been in place, and the formal training will need to be in place next year. Here's the basic list of helpful resources for infection control. Each of these web links here, from the CDC, from the Massachusetts Department of Public Health, from the AHRQ, and from ANZA, has a wealth of information. And I'll show you one example here, a screenshot from the CDC's website, Nursing Homes and Assisted Living page. And you may already be familiar, we've talked about this section here, which is the core elements of antibiotic stewardship for nursing homes, and we've gone through some of these resources in prior webinars. But on this side here, you see the National Nursing Home Quality Improvement Campaign. Although it focuses on C.diff, all of the elements that go into prevention of C.diff really apply to infection control as a whole. I'm going to go through some of these tools in more detail. But there are resources here on cleaning, on hand hygiene, on antibiotic stewardship, on containment, which I'll show you. And this is, if you scroll down on that same page, here are some implementation resources. The infection prevention and aging resource here, very useful. The AHRQ nursing home antibiotic stewardship tool is in here, and interfacility transfer form, which I'll show you. Down here you'll see specific tabs for CODI, more on C.diff, some information on carbapenem-resistant enterobacteriaceae, MRSA, norovirus, and influenza. So this is exhaustive and very, very useful. Best practices, pulling from those various resources, are to have written infection control policies that are based on evidence-based national guidelines, have mandatory training for your staff, to do an annual risk assessment. We talked about this in Infection Control Webinar 1. Do your annual risk assessment. There's an example. We went through it together, and so you can review those slides using that risk assessment to drive your initiatives. Where are your biggest risks? Where do you need to focus your energy and resources? Have a written surveillance plan based on your risk assessment, and update that every year because your risks are going to change every year. Have one or more individuals with specialized training. That could be a certification or a course in infection prevention, at least part-time. The infection preventionist should report regularly to the Quality Assessment and Assurance, QAA committee. You should be using root cause analyses to evaluate major adverse events related to breaches in infection prevention and to identify opportunities for systems-based modifications. And develop a system for early detection and management of symptomatic infected residents, both on admission, so make sure that you're reviewing transfer records and doing a thorough intake assessment. Again, you could use the templated form that's available on the CDC website. And thereafter, make sure that you're not missing new diagnoses of epidemiologically significant organisms by having a process by which you have notification that comes from your lab and goes to your infection preventionist. So let's get into some of the nitty-gritty implementation strategies. I'm going to say that the most common question that I have been getting throughout these webinars is about precautions. Who needs precautions? How do I implement precautions? What kind of precautions? Placement of patient or resident. Sorry, I'm from a hospital. I always use the term patient for mistake. And just probably above all, discontinuation of precautions. So I'm going to call your attention to this webinar, this URL from the Massachusetts Department of Public Health, where there are some really great summaries of the techniques that are required for each type of precaution. And I'm going to say right now that far and away, the most important type of precaution is standard precautions. And I'll even go out on a limb and say that probably if we were really nailing standard precautions, we wouldn't need all of the other types of precautions that we use. Contact precautions, mostly I'm talking about contact precautions here for our multi-drug resistant organisms, because standard precautions means that you're doing your hand hygiene after touching anything, really. Everything's listed here: blood, body fluids, secretions, excretions, contaminated items, which is really anything in the resident's room, whether gloves are worn or not. So that means that you are cleaning your hands or you put your gloves on, and after you take your gloves off, and really touching anything in that residence vicinity. Gloves are being used every time you're touching blood, body fluids, secretions, excretions, or anything contaminated with those things. You're using a mask and eye protection whenever there's a potential that there might be a splash or a spray of blood, body fluids, secretions, or excretions. This is what I think people forget to do the most. A gown is not just something that should be used for contact precautions. Gowns should be used to protect your skin and your clothing anytime that you may be exposed to a splash or spray of blood, body fluids, secretions, or excretions. And patient care equipment needs to be cleaned as well if it's being used for more than one resident. So, sorry, I have a freeze up here. So, of course, we have our droplet precautions, and we do need to use those, and the Mass Department of Public Health website lists the indications for droplet precautions. And I won't go through that in detail, but you have access to that in the slide deck and on their website. The contact precautions, really, if you look at what it means, it looks much like standard precautions, and it's implemented for a variety of infections, including our multi-drug-resistant organisms that we worry the most about in these conversations, potentially methicillin-resistant Staph aureus and VRE is where, and certainly CREs is where we tend to see it used most often, because those are the most common things that we see. And that's where we have a lot of confusion, because you want to discontinue contact precautions, and we're often confused about how to do that. And we're going to talk about that. Why do we have so much confusion? We have confusion because, for the most part, this stuff doesn't seem to make sense. And it's not just you. This stuff doesn't make sense to me either. Because giving contact precautions in patients who have MRSA, methicillin-resistant Staph aureus, and certainly we don't want to transmit MRSA between residents, but do we want to transmit methicillin-susceptible Staph aureus between residents? No, we don't want to do that either. We're also using contact precautions in patients or residents who might have something like a VRE or a MRSA bloodstream infection. And since when is a bloodstream infection going to hop out of a patient's bloodstream and right onto our hands or clothes? Certainly it's not. We also get confused because we know that we're isolating residents that have been identified to have a multi-drug-resistant organism. And we know that multi-drug-resistant organisms are very common. MRSA is extremely common. We may have, I speak at meetings of the National Association of Long-Term Hospitals, so long-term acute care hospitals, are telling me that their MRSA colonization rate is over 80%. So aren't we missing more residents than we're isolating? Doesn't it seem like if we're only isolating the ones we know about, there are probably, these are probably just a drop in the bucket or the tip of the iceberg of patients that are actually harboring these organisms? So what exactly are we trying to achieve here? We're also confused about why we're swabbing noses. Residents come in, they might have colonization or a history of infection or an active infection in a wound or a pneumonia or a surgical site infection, and we're swabbing their noses to take them off for precautions. Does that make sense? Why are we obsessed with noses? And furthermore, when we go to look up the guidelines and try to understand this a little bit better, they haven't been updated since 2007. That's a really long time ago. So what does the CDC say? The old guidelines from the CDC on contact precautions tell us that if a patient has an MDRO, and here they define that as, for example, MRSA, VRE, Visa reversal, which is vancomycin intermediate Staph aureus or vancomycin resistant Staph aureus. They mention ESBL, the extended spectrum beta-lactam resistant organisms, and resistant strep pneumo. They mention infection or colonization. And they say that the precaution should be contact plus standard. Well, of course, standard should be the case for all patients. But when you look at the comments, they say that MDROs are those that are judged by the infection control program based on local, state, regional, or national recommendations to be of clinical and epidemiologic significance. So that really leaves it totally wide open to interpretation. And your infection control program could decide that MRSA is not of epidemiologic significance. This goes on to say, contact precautions are recommended in settings with evidence of ongoing transmission, or acute care settings with increased risk for transmission, or wounds that cannot be contained by dressing. Wounds that cannot be contained by dressing? Well, that sounds like standard precautions, because standard precautions say that you need to use a gown every time you're dealing with somebody that has secretions or excretions that might get on your clothing. So, that's why I say that the most important thing here is to nail your standard precautions. And it says to contact State Health Department for guidance. So what does our State Health Department say? I'm here in Massachusetts, and our Massachusetts Department of Public Health does provide guidance on precautions and discontinuation of precautions. So, regarding discontinuation, there is currently no definitive data to support the decision about when to discontinue contact precautions. However, the resident's risk of transmission to others, so that could be their overall health, their dependence on health care, device use, all of those could be considered. But in most cases, the absence of active wound drainage, diarrhea, and copious contaminated secretions greatly reduces the risk presented by an infected or colonized individual. Again, this is really getting back to standard precautions. If your resident has active wound drainage, diarrhea, and copious contaminated secretions, you should be wearing a gown and glove to go take care of that resident, regardless of whether you know that they've had MRSA or VRE or anything else. Note, this does not apply to CREs, which are the most epidemiologically significant organism right now, and I'm going to tell you why and how that differs. So, how do you now take this information, which may be blowing your mind, and approach it in your infection control policy on contact precautions? I would advise you to write a policy that makes logical sense to you. Because if you understand why you're using contact precautions and when you're discontinuing them, if it makes sense, then you will be able to follow it and your staff will be able to follow it. If you can teach it in a way that everybody can appreciate, is logical, then it will work. You might isolate organisms that have the potential to be of clinical and epidemiologic significance, the way the CDC has recommended it. So, for example, as in the example I gave in long-term acute care, if your MRSA rate in your facility is greater than 80%, precautions may not be worth your resources. Consider focusing on the patient rather than the organism. You definitely want to use gowns and gloves if your patient has a weeping wound. You want to be using certainly masks and potentially gowns and gloves if your patient has a productive cough. If they're spraying sputum, you probably want to be protecting yourself. And patients who are incontinent of stool. Perhaps that is more important than whether or not they may be colonized by multi-drug-resistant organisms. And as I've said 3 times, make sure you're really nailing those standard precautions and that your staff understand them. You want to go over the sequence for putting on and taking off personal protective equipment. And if you quiz 10 people right now, I think you'll find that 9 out of 10 cannot tell you the order for donning and doffing PPE, and it's right here for your reference. And here's the removal order. So I told you that CRE really doesn't fall into this category of being optional, and that is because the CDC has labeled CREs, carbapenem-resistant enterobacteriaceae, as being the highest threat level, and that is threat level of urgent and immediate public health threat. The numbers are not huge. We're talking about 9,000 drug-resistant infections per year and 600 deaths. We know that the numbers for other multi-drug-resistant organisms are much bigger. But the issue is that they've become resistant to all or nearly all available antibiotics. And they cause infections with high mortality rates, up to 50%, And most importantly, they carry genes that have high-level resistance to many antimicrobials, limiting treatment options, and those genes actually can be transmitted from one organism to another, and therefore from one patient to another. The spread is rapid, and so this organism requires the most rigorous infection control measures that we have. We've already seen spread throughout many areas of the U.S., and we anticipate further spread. There are different mechanisms by which these Enterobacteriaceae become resistant. The transmission of resistance genes, and the production of enzymes that inactivate carbapenems, and we call those carbapenemes, and I'm going to explain why those are relevant. Transmission is person to person. Residents can contact each other. Healthcare personnel come into contact with these residents, and then can transfer the organisms on their hands, and contaminated medical equipment can transfer these organisms. Stool, wounds can have a high bacterial burden. Contaminated environmental surfaces can be a source. And any type of infection that you can think of can be caused by a CRE. So the Massachusetts Department of Public Health has a very comprehensive toolkit that you can see here, and the URL will be available to you for control of CREs. And the toolkit is divided into the acute care and long-term care settings. I'm going to pull out some information here just to highlight for you on the long-term care control of carbapenem-resistant Enterobacteriaceae and the mnemonic that's easy to remember. The Massachusetts Department of Public Health says, be nice. First of all, the first thing you can do is notify the Mass Department of Public Health that you think you have a CRE in your facility. I intervene, so you're going to launch into action with some aggressive interventions here, including a hand hygiene emphasis, a close look at your environmental cleaning and stepping up that process while you're focusing on reducing your unnecessary antibiotics, reducing your use of unnecessary invasive devices. And then if you have a certain subcategory of CRE, then even be more aggressive there. Communication is going to be extremely key here, not just at the time you identify the CRE, but for the duration of that residence in your facility. You're going to need to be communicating every time you transfer that resident in or out. And education. Once you have a CRE, you really want to step up that education of patients, staff, and visitors, and keep that going for as long as you can. Now, if the CRE is identified by the lab as a carbapenemase producer, so the laboratory that identifies the CRE is going to be asked by the Department of Public Health to send the isolate to the state lab, and they're going to tell MDPH and you whether that CRE is a carbapenemase producer or not. And the carbapenemase producers are really responsible for the worldwide spread of this resistance problem. They're easily transmissible, and they can transmit their resistance mechanisms to other bacteria. So in those cases, you're going to be extra cautious to be communicating and notify the Massachusetts Department of Public Health anytime that patient moves. So not just communicating between facilities, but anytime that patient moves, the Mass Department of Public Health needs to know. Your facility administration needs to be aware of this problem, and you're going to be asked to go back 12 months and review records to make sure you didn't miss another case of this type of organism causing infection or colonization. You're going to be asked to launch a full-fledged hand hygiene campaign with monitoring. You're going to be asked to quickly educate your staff, residents, and patients about CRE, and specifically CP, carbapenemase-producing CRE. And you're going to be asked to enhance your disinfection with implementation of an environmental disinfection monitoring system, so an audit of environmental surface and equipment disinfection. And there's going to be an expectation that you cohort nursing staff, so that you don't have any nurse in the facility authorized to take care of the CPCRE resident, but that you limit the number of nurses in your facility that have their hands on this resident. And if you have more than one case, you may need to keep them on the same wing with the same nursing staff. those patients will need to be in a private room residence. And if you have more than one case or a cluster, you're going to need to initiate active screening cultures, so rectal and perirectal cultures, to see if you have an outbreak in your facility. Any resident with CRE is going to need contact precautions. If it is not CPCRE, they should not be discouraged from participating in meals and activities provided their source of CRE is covered and contained. You will have the resources of the MDPH to help you on a day-to-day basis in managing this situation, and you will be advised to discontinue contact precautions when you have 3 negative rectal or perirectal cultures with some timing criteria there. You'll also need to culture the original site of infection if it is still present. So here's a handy-dandy table that you'll be using when and if you see a CRE in your facility, and exactly what types of precautions, including visitor recommendations, you take depends on whether it's a CPCRE or a non-CPCRE, and whether the patient is actively infected or just colonized.
I'm on mute, so it's like, you know what I mean, they can't hear me.
So here's a pop quiz for you. What is the most important thing you can do to prevent infection in healthcare? If you said hand hygiene, you win the prize. Hand hygiene is far and away the most important thing that you can do, you can teach your staff to do, that you can be monitoring in your facility. And CMS does require that you have a written hand hygiene policy outlining the practice for staff, residents, and visitors with training and competency for your staff, both upon hire and every year. I think we all know when hand hygiene must be performed. It's both before and after contact with the resident. Certainly before performing an aseptic test, after contacting blood, body fluids, visibly contaminated surfaces, but really any object in the resident's room, really any object the resident may have touched. After you remove your personal protective equipment, you need to do hand hygiene. After you use the restroom, before you eat, and when passing meds. And so here are 3 useful resources from the WHO, from the CDC, and from CMS that you can go to when you're developing your hand hygiene policy and your hand hygiene monitoring program. This is a nice graphic that we use here throughout our hospital, and many facilities have chosen to enlarge and post throughout their facility the famous World Health Organization 5 moments for hand hygiene. Does it really work? Does it really work in nursing homes? The answer is yes. Hand hygiene saves lives, and this is just a recent clinical trial using 26 nursing homes, a randomized control trial where half were randomized to receive a hand hygiene bundle that was aimed at residents, visitors, and staff, as well as outside care providers, contracted providers. Bundle included access to alcohol-based sanitizer, campaign posters, events, facility-specific guidelines, staff education, and consistent technique training. And what you can see here is that they were actually able to see sort of the baseline period and the early period, and as they went on, they were able to see a difference in mortality in the facilities that had the hand hygiene bundle intervention, and a difference on here as well in antibiotic usage. So lower mortality, lower antibiotic usage in facilities with better hand hygiene, which certainly we believe correlates with a lower infection rate, which is more difficult to monitor. So what are your modalities? 2 options, soap and water or waterless. Now, if your hands are visibly soiled, you need to use soap and water. In any other case, it is perfectly acceptable and perhaps better to use a waterless alcohol-based hand sanitizer. Soap and water requires an infrastructure requirement. You have to have access to a sink. And soap and water can be more effective by poor technique, especially when you're talking about the residents themselves doing hand hygiene. Waterless, on the other hand, comes in a variety of different products, including wipes, which can be very useful for your residents. It's faster to perform. It's much more easily accessible. And I would say that when in doubt, install more dispensers, but make sure you're following fire codes, because alcohol-based sanitizer is flammable, and there may be some issues there. But wherever you can put a dispenser, put one. It is less drying to use hand sanitizer. It's a little bit counterintuitive, but because there's moisturizer in it, studies have shown better skin integrity after sanitizing than after washing with soap and water. Studies, this is an old one, but just to let you understand, studies have repeatedly shown that the alcohol-based sanitizer is more effective at reducing microbe counts on skin as compared to soap and other antibacterial products. And they've also shown very clearly that the more access you have to hand sanitizer dispensers, the more dispensers you put in useful places, places where people need them when they're done taking care of patients or residents, the higher your compliance rate will be. A big question I get asked a lot, do I need to use soap and water after caring for a resident with C.diff? Actually, I don't get asked this question as much as I would like. There are many people who presume that the answer is yes, and it's not actually that clear. Now, the CDC guidelines, which haven't been updated since 2002, say this: none of the agents, including alcohol, chlorhexidine, hexachlorophene, iodophores, all of the agents that are out there, used in antiseptic hand wash or antiseptic hand rub preparations are reliably suicidal against Clostridium species, or for that matter, Bacillus species, the agent that causes anthrax. Washing hands with non-antimicrobial or antimicrobial soap and water may help to physically remove spores from the surface of contaminated hands. Workers should be encouraged to wear gloves when caring for patients with C.diff-associated diarrhea. After gloves are removed, this is key here, hands should be washed with a non-antimicrobial or antimicrobial soap and water, or disinfected with an alcohol-based hand rub. During outbreaks of C.diff-related infections, washing hands with soap and water after removing gloves is prudent. So they don't say must or should or is required. They just say is prudent during an outbreak. They also don't define an outbreak. And that was 2002. Well, this is just a slide here to remind you not to forget about fingernails when you're thinking about your hand hygiene policy and your training. Natural nail tips should be short. Nail polish should not be chipped, and absolutely no artificial nails should be worn by anyone who's touching residents or anything that comes in contact with residents. So in 2011, the CDC came out with a statement, and it was endorsed by all of these groups here, SHEA, APIC, IDSA. The rationale for their hand hygiene recommendations after caring for a patient was Clostridium infection, Clostridium difficile infection. And they reiterated their stance. And they were responding to questions that frequently arise regarding why they don't require soap and water hand hygiene in cases of C.diff. And they said that although some have found that some studies have found that hand washing with soap and water is more effective at removing C.diff spores than alcohol-based hand hygiene products. But the primary reason hand hygiene with soap and water is not recommended for C.diff infection prevention in non-outbreak settings is that there are no studies that have found an increase in C.diff infection with the use of alcohol-based hand hygiene products, or a decrease in C.diff infection with the use of soap and water. Conversely, several studies have identified decreases in methicillin-resistant Staph aureus, or VRE, with the use of alcohol-based hand hygiene products. Or alcohol-based products are more effective at killing the bacteria, the multi-resistant organisms that we get on our hands, and neither product kills C.diff. And so as a result, combination of these findings, lack of change in CDI with decrease in other non-spore-forming MDR pathogens, with the use of the alcohol-based hand hygiene product is the basis behind our not recommending preferential use of soap and water for C.diff prevention in non-outbreak settings. However, because of the theoretical increase in the risk of C.diff transmission, based on the volunteer hand contamination studies, so not real-world studies, the experts who wrote the C.diff component of the guidelines. Felt it was prudent to recommend preferential use of soap and water after caring for a patient with CDI in an outbreak setting. That is the guideline. And this again is from the Massachusetts Department of Public Health website and hygiene techniques.
Hey, Shira, are you finding that background noise? It's distracting.
Yeah, why don't we take a break here just to remute all the lines, and I'll unmute my line after you do that.
Okay, I have to unmute and then remute everyone. It'll be 2 notes.
The leader has unmuted your line. The leader has muted your line. To unmute your line, press #6.
Okay, much better. So here are some details from the Massachusetts Department of Public Health on how to do hand hygiene, but I also provided these 2 diagrams for you that I would also recommend using in your education to your staff. Post these in key areas, exactly the steps to take. There are 11 steps for hand washing and 8 steps for the use of waterless hand sanitizer. And you want to make sure that your staff are doing that appropriately and that they can demonstrate competency there. In the National Nursing Home Quality Improvement Campaign C.diff prevention activities part of the CDC website that I showed you earlier, there are a number of tools, and one of them is a hand hygiene assessment tool where you can go through, and again, this can help you in development of your policy, assess the knowledge and competency of your staff, assess the adequacy of your policies and infrastructure, and determine what types of monitoring practices you want to implement. So I encourage you to take a look at that resource. And there are lots of strategies that have been proven to improve hand hygiene rates. There are really so many studies out there that have shown a success in improving hand hygiene rates. Providing staff with moisturizer or lotion soap that help with their skin integrity, but can be really helpful because we know that one of the barriers to appropriate hand hygiene is dry, cracked skin. But keep in mind that lotions may not be compatible with your hand hygiene product, and you do want to touch base with the manufacturer of your hand hygiene products, particularly your soap, when you are purchasing any kind of moisturizing lotions for your facility. When you monitor compliance, which is really important, ways to use that data to drive improved compliance are to de-identify and circulate that data. So here's your compliance versus everybody else, for example, or to create internal competition between units, job classes. Things like, who's gonna win the prize this month? Is it 2 South or 2 North? Engage nurses by their cause. Every time you perform hand hygiene is an opportunity to demonstrate how much you care. You want to get creative with your slogans, with your signage. And when it comes to residents, we know that providing alcohol-based sanitizer packets with meal trays is a way to increase hand hygiene before meals, and that they may need multiple modalities and visual and verbal reminders. But you don't want to forget about your residents and your visitors with your hand hygiene initiatives. A quick word about sharps. Obviously, this is something that you want to make sure you've got great policies and procedures on, that you've got training and competency both upon hire and annually, that you're doing audits, and certainly as it relates to diversion of controlled substances, this can be an area of focus for your institution. One area that people get tripped up on, multi-dose vials. They can be used for more than one resident, but not if they enter that resident's care area. So unfortunately, you cannot do a finger stick and then have the insulin in the room ready to use. Point of care devices. surprisingly a pretty big source of outbreaks. If a device cannot be dedicated to one resident, then it must be cleaned between residents. How do you clean a device? You clean it according to the manufacturer's IFUs, instructions for use, and you need to make sure you have those readily available for every device in your facility. There have been a surprising number of hepatitis B outbreaks in long-term care associated with equipment, and I just listed here a table just showing the outbreaks in the United States just between 2010 and 2016, and I just put the table together just to show you how frequently those outbreaks were due to either glucometers or finger stick devices. And then in summary, there have actually been 18 outbreaks in long-term care alone between 2008 and 2016, with at least 133 cases of hepatitis B related to those outbreaks and over 1,500 persons at risk. And 83% of those outbreaks were associated with infection control breaks during assisted monitoring of blood glucose. So this is a really important area to make sure you're focusing on. If your facility has residents with central lines, this is a huge, this is a type of infection that has a huge morbidity and mortality associated with it. So you want to make sure that you've got your policies and procedures in place, that you've got your individuals trained and demonstrating competency in accessing and maintaining those central venous catheters. Where we get tripped up here, and I'm sure you do too, scrubbing the hub for 15 seconds. And many facilities, if not most, are struggling with the requirement to assess the need for that device daily and document that. And certainly the device should be promptly removed if it's not 100% medically necessary. And here on the CDC website, you'll find a checklist for the prevention of central line-associated bloodstream infections, and that's on the web page that I showed you earlier. Urinary catheters. You'd be surprised at how small the list is of acceptable indications, and there needs to be documentation for the rationale, but it's really just retention, bladder outlet obstruction, neurogenic bladder, and terminally ill. It really should not be used strictly because a patient is bedbound. Again, competency, training, you want to make sure these devices are secured. You want to make sure that the spigot doesn't touch the collecting container when you're emptying it. The bag is below the bladder and off the floor. And just remember that a resident cannot develop a catheter-associated urinary tract infection if they do not have a catheter. Essentially, all patients will have a positive urine culture within about 2 weeks of having a catheter inserted. Environmental cleaning and disinfection. Such a tough topic because it's something that many of us don't have a lot of training or experience in, but such an important piece of your infection control program and your infection control policy. And there are so many aspects. There's the routine cleaning, and then there's the terminal cleaning and disinfection of the room. There are high-touch surfaces, and then the rest of the surfaces. There are the curtains. There's equipment as it might differ in its cleaning protocols from the room itself. There's reprocessing of sterile equipment. So training and competency should be assessed every 12 months. There should be some way to do audits and feedback on the quality. You need to make sure that you have a chemical in place, not necessarily for every room, but for those rooms where you know you have C.diff or norovirus. Not every chemical is active against those organisms. And here's where people get tripped up. Separation of clean and dirty. So you can't have any clean items like clean linen cloths or clean equipment in a dirty resident room or a dirty utility room. And you can't have dirty items like dirty laundry equipment in your clean utility room. Nor can you bring your dirty linen card into your clean resident room. Literacy and language barriers can be a big issue when it comes to your cleaning staff. And you may have a contracted service provider, so your staff may not be actually employees of your facility, and that may take an extra step to ensure competency. Do the housekeeping staff need instructions in other languages or visual cues to ensure that protocols are being followed? So here's an example that we use at Tufts Medical Center. This is our modified contact precaution sign that we use on the door of rooms where the patient has C.diff. But this is the sign that we use to alert housekeeping to how that room should be cleaned. So every patient who is identified as having Clostridium difficile infection has both of these signs put on their door. The B tells the housekeeper to clean that room with bleach. When contact precautions are discontinued because the patient is no longer symptomatic, this sign comes down and the B stays up until the patient has been discharged from the hospital, alerting the housekeeper that they need to clean that room with bleach right up until and through the terminal clean of that room. So on the MDPH website, cleaning and disinfection guidelines for your reference. Has some specific information about trash handling, linen handling, and more. I would recommend that you make sure you have a policy for the cleaning responsibility framework of resident equipment. This is a sample policy, and this is a hospital-based policy, so there are some items here that you want to have. But what it does is it lists items, so equipment, essentially, that come in contact with residents, how those items are to be cleaned, when, with what, and who is responsible. So some of these items are going to be cleaned by your housekeeping staff, and others are going to be cleaned by nursing staff or nursing assistants. And it's important to have that all outlined in writing. Another really good practice is to clearly label clean and dirty equipment as clean and used or dirty, so you know where that equipment should be kept, whether it's a clean room or a dirty room, and whether you can use it for another resident. Respiratory policies should address tuberculosis screening and visitors that potentially may have a respiratory infection. Respiratory etiquette signs, such as cover your cough signs, are a good thing to have, and we do want to make that part of our annual re-education plan. When it comes to C.diff, early identification and rapid containment is the key. So you want to have a protocol for notifying medical personnel when a resident develops diarrhea. You don't want that to simply be known to a nursing assistant and no one else, for example. You may want to have a policy that allows nurses to collect and order stool for C.diff, but I find that to be very controversial because we do see that C.diff tests are being over-ordered and oversent, and therefore C.diff over-diagnosed and over-treated, and we've talked about colonization versus infection. So if a resident gets a bowel regimen or a laxative and then has diarrhea, that's not a situation where you would want to send stool for C.diff. And you want to have a protocol where medical personnel are then notified very quickly about positive test results so that you can implement your rapid containment. You may want to have a policy that allows nurses to implement isolation when the resident develops diarrhea, and certainly when that test comes back positive. Visual tools to communicate that to the residents on isolation precautions. Certainly make sure that you always have adequate supplies of gowns and gloves appropriately placed for those residents who need them. Dedicated equipment for those residents with C.diff, and a policy separating their toilets or commodes if they share a room. And again, this toolkit here on the CDC website has some best practice guidelines here for the early identification and containment of C.diff. Different from other multi-drug resistant organisms, you do want to discontinue when there's no diarrhea for 72 hours, discontinue those contact precautions. You don't want to share items between residents. Do not, under any circumstances, repeat the C.diff test. That will be positive indefinitely and will not help you in any way. You do want to restrict movement of those residents when they're symptomatic, but then allow them to participate in group activities once their diarrhea has resolved. Just making sure their hands and clothes are clean and their body substances are contained. The Mass Department of Public Health has specific guidance which you would probably find useful on room placement for those patients with multi-drug resistant organisms and C. diff. Single patient rooms are preferred, but we know that is not always possible. If the patient has C. diff, a private bathroom would be great. Again, we know that's not always possible. If you can cohort those residents together that have C. diff, whether it has an MRSA or BRE, that's ideal. Again, not always possible. So if you're using multi-resident rooms, try to keep those residents more than 3 feet apart and minimize the sharing of items between them. And decisions regarding placement should be made on a case-by-case basis. Again, balancing the infection risk against the psychological impacts and the needs of those residents. These 2 links here are the EPA.gov websites showing you what products kill C. diff and norovirus, and you want to make sure that what you're using in those rooms it actually has the capacity to kill those organisms. And really important and often forgotten, contact time, also known as kill time or dwell time, the amount of time a product needs to remain on a surface that means wet in order to be effective against that microorganism. And the same product might have a different dwell time for C. diff versus something else, so it might be longer for C. diff and shorter for regular bacteria. But longer contact times may mean that that housekeeper needs to stay there and keep reapplying, which may actually be unrealistic. So you should take into account your contact times. There are some no-touch technologies that are expensive that are being used in hospitals to kill microbes, including C. diff, ultraviolet light, hydrogen peroxide, and electrostatic sprayers. Just want to point out this CDC website with some key infection control recommendations for the control of norovirus. And there are some unique aspects to that infection, and certainly in terms of staff leave and making sure that your staff never come into work with symptoms that could be consistent with norovirus. I've listed here some of the things you want to make sure you're doing competency verification on, and don't forget your contracted providers, podiatry, ophthalmology, your dentist, your wound specialist, to bring in their own equipment. And here is that interfacility communication tool that I mentioned, which can help you to identify issues before you even bring somebody in and to alert other facilities when you're sending somebody out. Really exciting news. Their CMS will be offering infection control practitioner training through a program sponsored by the CDC. So in spring 2019, it will be free of charge. It will meet that phase 3 requirement. It will be available on demand, 16 to 20-hour training with a certificate provided upon completion. So we're really excited about that. I'm going to open it up to questions. You can type those questions into chat. I can turn back over the slides to who would like the slides.
Can you indicate, please?
One of the last slides. I'll just turn back over the speaking to whoever would like to talk about the future QIN-QIO webinars while I take a look at the chat.
Hey, it's Kate. Could you pass the ball back to me, please?
Sure can.
And we will open up the call now for questions. We do have one question open in chat. I can read it if you like. Does it make sense to keep a soap and water policy in place for each C. diff case, given the turnover floating that occurs with the communication risk of direct caregivers not knowing whether or not an outbreak has been defined for a particular unit?
Yeah, so that's a good question. What is the definition of an outbreak? And I will tell you that we have had spikes and clusters of C. diff in our hospital, and we've never defined that here as an outbreak. And the reason being that we know so clearly that hand hygiene compliance, when you try to require soap and water, is so much lower, so much poorer than when you give people the option to use the wireless hand sanitizer, which is so much easier to do and more available. So I would say that unless you're in a situation with C.diff where the Department of Public Health is saying there's a problem here, or you're having to contact the Department of Public Health because you're seeing such a spike, I personally don't recommend that you have a blanket policy of soap and water for C.diff. Yeah, that's my personal opinion. I think that others might approach it differently.
I know we didn't talk about it, but what is the recommended duration to have contact precautions for a patient who has completed treatment for ESBL in the urine?
Right. So there is no recommended duration. And there is really certainly no evidence behind any particular approach to duration. If you are isolating residents with ESBLs, and we don't use any precautions for patients with ESBLs here at Tufts Medical Center. If you are, one kind of logical approach might be that if the infection has resolved, then you could discontinue isolation precautions. And I would never, ever advocate doing urine cultures in asymptomatic patients. So because we know that these elderly patients have positive urine cultures when they don't have infections, and when we see those positive urine cultures, we feel compelled to treat them for psychological reasons. So I would not recommend doing that, and I'm not even sure that I would recommend putting them on isolation precautions in the first place.
I want to skip ahead to one where we need to go back to a slide to clarify. On slide 28 that I just pulled up here, when you talked about MRSA rate at 85%, you were referring to a colonization rate. Is that correct?
Yeah, I was giving an example of some facilities that I've interacted with in my work with long-term acute care, and particularly on the West Coast. There are some facilities who boast, I'm joking about that, but who claim that their MRSA colonization rate, if they were to do screening, is on the order of 80–85%. And so they decided years ago that there is no point in using contact precautions for MRSA. The colonization pressure, the burden of that organism within their institution is so great, and it is so unlikely that any of the residents who are not colonized either are truly uncolonized or are going to avoid it for long. They decided to put their resources elsewhere.
Thanks everyone for all your great questions. We are super short on time, so we can follow up after the fact for those of you who want to put your questions in chat, but we do want to make sure we have a moment for closing remarks here. When you close out of this webinar, an evaluation will automatically pop up on your computer. If you can please fill that out, we'd greatly appreciate it. Don't forget to mark your calendar for the remaining webinars for the series. Check our website for more information or contact your state lead. The state lead information is on the last slide. And now I'll turn it over to Sarah, who will talk about our New England Nursing Home's commitment to quality improvement.
Thank you, Kate. The New England QIN-QIO wanted to thank those nursing homes participating in the New England Nursing Home Quality Care Collaborative who have been actively engaged in collaborative activities and committed to quality improvement. To recognize your continued engagement, we sent a quality commitment badge to those facilities to display in the window of your front entrance. If you've been actively engaged in the collaborative and did not yet receive your badge, these were mailed to the attention of the administrator over the last several weeks. Please contact your QIN-QIO state nursing home lead. If you have received your badge, we're asking you to share your commitment to quality. Take a photo of your badge displayed in your front entrance. Bonus if staff are included in that photo. Post it to social media using the hashtag #WeCommitToQuality, that's number 2. And tag the New England QIN-QIO on Facebook, Twitter, or LinkedIn. Our social media handles are listed here on this slide. Next slide, please. Facilities who post their photo using this hashtag and tagging us will have a chance to be featured in New England QIN-QIO social media postings, newsletters, and programs. Congratulations to the New England homes for the best. for their continued engagement and for celebrating their commitment to quality. Several others have shared their photos as well, including members of their staff. So please take a look out for other collaborative communications to see if your facility has been highlighted. Next slide, please. Also, in addition to our appreciation for your commitment to quality, later this year we will be announcing the New England Nursing Home Quality Care Collaborative Award winners. Nursing homes will receive a ribbon, either blue or gold, to display along with your quality commitment badge to acknowledge your accomplishments during the collaborative. The awards program winners will be determined by the criteria that's listed here on this slide, and it's not too late to secure your award. The next step towards achieving your collaborative quality award is to submit a success story. New England QIN-QIO continues to spread best practices throughout nursing homes in New England, and we're asking for you to share yours. Keep a lookout for an email going out later this week with a link to submit your success story. We'll be highlighting a success story of the month on our monthly newsletter and highlighting your successes with CMS. If you're ready to share your success story, I've also included a link to submit it in chat below. Back to you.
Thank you. I just want to make sure everyone sees this last slide up here, and we can go back and possibly answer a few more questions since we still have the line for a few more minutes. I know we probably lost some people, and we can try and follow up with those people directly via email, and we'll have a thank you email that goes out in a day or two. So a question that we said we'd like to follow up on, the competency verifications of contracted providers. What exactly are you looking for?
Right. So I actually mentioned contracted providers in two kind of different, contractors in two contexts. If you are thinking of providers, I was talking about people like ophthalmology, optometry, podiatry, wound care specialists. And for them, I was really referring to essentially making sure that they are adhering to all of your facility policies. So that means making sure that they do the same education and competency verifications that your staff do for hand hygiene, for contact precautions, or isolation precautions in general, for equipment cleaning. And that's really important. You have to make sure that they're cleaning their equipment according to your standards. You want to make sure that they're following your protocols for your respiratory policies, so their tuberculosis cleaning, et cetera. So all of those things. When I was talking about outside contractors for environmental services or housekeeping, there what I am thinking about is making sure that there's verification that they're following the exact protocols that you've agreed upon with that contracted provider for cleaning and disinfecting of rooms and equipment, whatever equipment might be under their purview per your equipment cleaning policy. So there needs to be some verification. You need to know that they're doing what you've laid out in your policy, and not just trust the contractor to ensure that.
Okay, we did have one question that went just to the host that I wanted to grab before we close. Does a colonized resident need contact precautions or just standard?
Especially with a multi-drug resistant organism like MRSA, VRE, ESBL, those are the tip of the iceberg, and there are many, many more that are colonized, and that all of those colonized residents have the potential to transmit organisms from resident to resident, resident to healthcare personnel to resident. But whether contact precautions are really the intervention that's going to change that is not clear. I would argue that standard precautions and using standard precautions every single time standard precautions are indicated is much more important than trying to figure out who qualifies for contact precautions and who doesn't. So again, this goes back to my earlier slide about making sure that whatever policy you're using makes sense to you. So if you're unclear about why a colonized resident needs contact precautions, it's probably because whatever you're doing isn't making sense to you. And a colonized resident may not need contact precautions, although that may be the standard right now. And I think that we do need to kind of relook at that standard. So yes, a colonized resident can transmit their organism that they're colonized with without being infected, but a resident colonized with a non-multi-drug resistant organism can transmit that organism just as freely as a resident colonized with the analogous drug-resistant organism. So there is no hard and fast rule. There is no hard and fast CDC guideline on who needs contact precautions, and they don't distinguish between colonization and infection. But you definitely need to be using gowns and gloves when you're dealing with open wounds, body fluids, mucous membranes, etc.
Thank you so much. Now we are over time. I'm just going to wrap it up now. If you have any questions that weren't addressed, feel free to reach out to your state leads. On this page here is our contact information, and we can forward the questions as needed to you, Shira.
Sure.
Thank you so much. Have a great day, everyone.
The leader has disconnected.